multiple sclerosis, results of a randomized placebo-controlled pilot trial by Dr. Spain.
Thank you to the committee for inviting me to present my work to you today. There are no relevant disclosures from the authors. Because of the collective efforts of many, we are fortunate to be practicing neurology in an era of many effective disease-modifying therapies for relapsing MS. However, DMTs for progressive MS, especially those with long-standing disease and advanced disability, are still sadly lacking. Lipoic acid is an inexpensive, small molecule antioxidant with multiple biological functions. The R enantiomer of lipoic acid is produced endogenously in mitochondria, where it plays a key role in oxidative respiration. However, synthetic production produces the racemic mixture of both R and S enantiomers, which is also the most commonly available form. Lipoic acid has a disulfide bond that is reduced by hydrogen into dihydrolipoic acid, and the cycling between the oxidized and reduced forms lends to the actions. Lipoic acid is effective in the murine model of MS. There are a number of functions of lipoic acid that have therapeutic potential in progressive MS. Among others, these include a role in endothelial cell function, which may be important in maintaining an effective blood-brain barrier, and inhibition of inappropriate microglial activation. Lipoic acid supports mitochondrial function as a key cofactor for the pyruvate dehydrogenase complex of oxidative respiration. It also aids synthesis of mitochondrial nucleic acids. Lipoic acid is effective in experimental autoimmune encephalomyelitis. 4 different laboratories have shown a reduction in disability in mice treated with lipoic acid. And these studies also show reduced lymphocyte and macrophage infiltration into the spinal cords in EAE. Here I show a dose-response curve of EAE disability suppression in experiments performed at our center. In people, the main side effects of lipoic acid are gastrointestinal upset and malodorous urine. Based on this preliminary work, we conducted a 2-year, double-blind, randomized controlled trial with a classic 1-to-1 design of daily oral 1,200 milligrams racemic lipoic acid versus placebo in secondary progressive MS with the following specific aims. 1, to compare the annualized percent change brain volume as measured by Sienna. This was the primary outcome. 2, to compare changes in disability and quality of life. And 3, to assess safety and tolerability. The sample size was based on a 2009 paper by Altman et al. The assumptions included whole brain atrophy rates by Sienna, a 2-year study design with yearly MRIs, and a 60% effect size. The calculated sample was 23 per arm, which we increased to accommodate dropouts. The intention to treat analysis used a linear mixed model approach to evaluate the effects of lipoic acid on annualized rates of change in outcomes. Models were corrected for age, sex, and MS duration. This provided 80% power with a significance set at less than 0.05. The flow diagram shows the main study outcomes measured at baseline, 48 and 96 weeks. Safety labs were collected at all 7 study visits. Of the 54 randomized patients, 3 withdrew before taking study drug, such that the intention to treat placebo cohort had 24 patients, and the lipoic acid cohort had 27 patients. There were 5 dropouts in the lipoic acid cohort only. 1 person had claustrophobia and couldn't tolerate the MRI. A second had nausea and vomiting, which resolved when stopping the lipoic acid. And a third had a new diagnosis of prostate cancer. The fourth had new proteinuria, and the 5th had worsening renal function, which I'll discuss later. The 2 study arms were well matched at baseline and were typical for a secondary progressive cohort. Here I point out that this study had older patients of nearly 60 years and longer disease duration of average 30 years, also greater disability than is typically seen in progressive MS trials. The primary outcome was a difference in annualized percent change in brain volumes. The placebo group had an annualized atrophy rate of 0.65%, which is comparable to other progressive MS natural history cohorts. Lipoic acid resulted in a lower annualized atrophy rate of 0.22%, which was significantly different from the placebo cohort with a p-value of 0.004. This represents a 66% reduction in the rate of brain atrophy in the lipoic acid cohort compared to placebo. No other outcome demonstrated significant differences between arms at 96 weeks, although there was a trend toward improved time to complete the timed 25-foot walk in the lipoic acid group. This represents a change from approximately 8 to 7 seconds, or about 12%. This study was not powered to meet clinical endpoints. As expected from our previous studies and the literature, gastrointestinal upset was significantly greater in the lipoic acid arm. Unexpectedly, there were half as many falls reported in the lipoic acid arm. Along with walking speed, falls will be explored in more detail and prospectively in follow-up trials. Two notable adverse events in the lipoic acid cohort were a case of new onset proteinuria and a patient with baseline elevated creatinine who had worsening renal function during the study. Both of these two patients dropped out of the study. A consulting nephrologist did not think either were related to the lipoic acid, and renal events have not been noted in other trials of lipoic acid for other conditions. The dropout rate was less than 10% overall, and compliance as captured by pill counts was greater than 80%. The conclusions of this pilot randomized controlled trial are that daily oral intake of 1,200 milligrams racemic lipoic acid significantly reduced whole brain atrophy rates in secondary progressive MS, and that lipoic acid was overall safe and well tolerated. These results need further exploration with a larger sample size to clarify the effect size of lipoic acid, to determine the clinical benefits associated with reduction in brain atrophy, and to explore the mechanisms of action of lipoic acid in progressive MS. The research was supported by the United States Department of Veterans Affairs, the United States National Institutes of Health, and Pure Encapsulations generously provided the lipoic acid and placebo. Special thanks go to Beth Hariza, the lead study coordinator, also my co-investigators, and to you today. Thank you.
Okay, very good. Questions? In the back?
Yes, Wiley from Melbourne, Australia. This is a very interesting study, and I wondered if there's any similar trials on the use of a different self-hydral reagent, N-acetylcysteine, which has been used experimentally in a number of neurological conditions, mainly psychiatric. Do you have any comparison with other self-hydral containing compounds given orally?
That's a good question, and it was asked to me earlier this meeting. I don't have the answer to that yet.
Other questions? There's one right there.
Sridhar Narayan in Montreal. I was wondering, when you plan further studies developing this agent, if you would consider using markers, in vivo markers of oxidative stress. You could use, for example, MR spectroscopy to measure brain glutathione, which might help to elucidate the mechanism of action of lipoic acid.
That's an excellent suggestion, and I'd love to talk to you further about that.
Okay, thank you to our presenters. Thank you all for staying.